So I just want to let everyone know that this light is super bright, and I guess it was set up for people who are videotaping, so I can't really see anyone. So if you have a question, just put up your hand and kind of yell. My topic today is urethral cancer. Our objectives, we'll review urethral cancer completely and then touch on urethral recurrence after cystectomy, then urethral cancer within urethral diverticulum. So urethral carcinoma is quite rare. It makes up about 1% or less than 1% of all male and female genitourinary cancers. It's usually found in males and females over the age of 50. And it's the only genitourinary cancer that's more common in females. It's about 4 times more common in females than in males. 85% of patients are white. The incidence, it's quite rare, and the disease is quite aggressive. There's much controversy about optimal management, so I thought it would be an interesting topic. It was sort of lead in from my previous grand rounds on urethral diverticulum earlier in the spring. The etiology in males is usually from chronic inflammation, STDs, strictures, urethritis, as well as HPV-16 and squamous cell carcinoma. Females, that also plays a role, as well as caruncles, parturition, leukoplakia, and again HPV-16. You can classify urethral cancer according to primary versus metastatic, according to location, anterior versus posterior urethra. And we'll get into the anatomy a little bit later. The histological subtype and staging, either superficial versus invasive, simply, or according to TNM staging. So this is a little bit of anatomy and histology looking at the male urethra. The urethra can be divided into 2 divisions, sort of an anterior and a posterior division. The anterior division drains to the inguinal nodes, and the posterior to the pelvic nodes. The anterior division is made up of the bulbous and penile urethra, and the posterior, the membranous and prostatic urethra. You can see that the different urothelium changes along the urethra, from the bladder to the urethral meatus, with transitional cell being common in the, or prevalent in the prostatic urethra, lining the prostatic urethra. You have stratified or pseudostratified columnar epithelium along the bulbous and penile urethra, and then stratified squamous in the fossa navicularis area here. Because of these different urothelium, you therefore, whenever you get any dysplastic changes, you get either TCC, SCC, adenocarcinoma. This is just a cross-section, again, of the penis here. You can see the urethra running through the corpus spongiosum and the cavernosal bodies here. So the blood supply of the urethra is important in the male urethra because of the amount of crazy origami that we do usually with it in terms of reconstruction and in terms of penectomy and resection. It's considered a dual blood supply. You have antegrade flow coming from the internal pudendal artery, which runs into the common penile, and then divides into the bulbourethral artery, which penetrates the corpus spongiosum and feeds the urethra. You also have the cavernosal arteries that penetrate the cavernosal bodies, and the dorsal artery, which runs between the corpora cavernosum and feeds the cavernosum, the spongiosum, and the glands through circumflex arteries. There's also retrograde flow going from the glands to the corpus spongiosum because of their intimate association. That's coming retrograde from the dorsal artery. Looking at the female urethra, again, it's divided into the anterior and posterior divisions. Anterior is just generally the distal 1/3 of the urethra. That drains into the inguinal nodes. The posterior division comprises the proximal 2/3, and those drain into the pelvic nodes. Looking at the different histological histology of the urothelium, the proximal 1/3 of the urethra, of course the female urethra is quite short, it's about 4 centimeters. Proximal 1/3 is comprised of transitional cell urothelium, and then the distal 2/3 squamous cell. Therefore, you'll have more TCC or SCC depending on where in the urethra you have the changes. You also have adenocarcinoma, which is quite prevalent as well. So in terms of histological subtypes for urethral carcinoma, the main one is squamous cell in both males and females, comprising about 70 to 80% of the histology. In males, TCC is the second most common, 15%, and 5% sort of a grab bag of different pathologies, adenocarcinoma, melanoma, etc. By location, 60% of the urethral tumors are found in the bulbomembranous urethra. 80% of these are squamous cell, 10% TCC. 30% of the urethral carcinomas are found in the penile urethra, 90% of these are SCC, and 10% of the prostatic carcinomas, you have TCC comprising 90% of them. In the female cohort, the second most common histological subtype is adenocarcinoma, makes up about 25%, generally related to a lot of the urethral glands covering the female urethra. It's the most common form found in urethral diverticulum. And there's a 10% incidence of TCC. Looking at spread, it's usually by local extension in males, the vascular spaces of the corpus spongiosum and the periurethral tissues. Lymphatics we've already talked about. If it's anterior urethra, it goes to the inguinal nodes, and posterior to the pelvic nodes. And hematogenious spread in both male and females are uncommon. When it does happen, it happens to the landing sites are lung, liver, bone, and brain. Females are local extension, and distally it will go to the skin or vulva, and it can cause ulcers. Proximally, it will extend to the vagina or bladder. Most patients, almost 100% of patients, are symptomatic. They present with urethral bleeding, obstructive voiding symptoms, a palpable or bulging mass, frequency, dysuria. So that's pretty good because we'll discuss a little bit further. History and physical are sort of your mainstays. You want to make sure that you palpate for any inguinal nodes. Urine cytology is of a questionable importance, and we'll come back to that a little bit later. Cystourethropy and biopsy, either TUR or needle biopsy, is recommended. If it is a urethral adenocarcinoma, you need to consult gastroenterology for arrangement of a colonoscopy to rule out a colon primary. EUA is important, so exam under anesthesia. You want to do a bimanual of the rectum. If you feel anything or you feel that it's invading, you should arrange for a flexible sigmoidoscopy at the same time. And also palpate the perineum, urethra, external genitalia. CT abdo-pelvis looks for just kind of local spread, soft tissue, lymph nodes, bone. MRI shows invasion of the corpus cavernosum, can be quite helpful, and chest X-ray for more lung mets or distal mets. So looking at cytology, whether it's a really good tool or not, it was found by Touget and Dalbagny in 2004 that it was not very reliable to diagnose primary urethral carcinoma, but it does have some use. 41 females and 29 male patients with primary urethral cancer were looked at. 59% of the females and 55% of the males had positive cytology, so not a very good pickup rate. The sensitivity was highest in patients who had SCC in females, 77%, and highest in males with TCC at 80%. The 73% sensitivity in men with tumors of the pendulous urethra. So it's not really a great diagnostic tool. However, it's one of the things that we have, so it's commonly utilized. It's part of the regular screening for urethral recurrence of cystectomy. However, because most patients are symptomatic, anyone should be well worked up. This is just a cool picture, retrograde urethrogram, showing an irregular stricture of the bulbous urethra here. This is a guy who had obstructive voiding symptoms. This is his MR that he went on to have. Here it's a T2 weighted MR. See the mass here in the urethra, the big M on it, and the corpus spongiosum here. You can see on axial imaging that it shows that the corpus cavernosum are not invaded. These are the cavernosum here. What happened to my arrow? Here, and the urethral mass is right here. This is a voiding cystourethrogram of a female who complained of incomplete emptying. So, of course, history and physical exam, very key. She went on to have a VCUG. This shows irregular narrowing of the urethra and all of these irregular sinus tracts that are coming off from the urethra. She went on to have a diagnosis of urethral carcinoma. This is a different patient. but showing an MR in a 40-year-old lady with a large urethral carcinoma. This is a T1 weighted fat suppressed MR, post-gadolinium. You see the urethral mass enhancing here. These arrows are just pointing to the smoothness of the vaginal wall. You can see that there's no invasion. This paper was looking at using vaginal gel in order to increase the sensitivity of the MR studies. This is the vaginal gel here within the vagina, and this is the smooth outline of the vagina that's being shown. The folia is being pointed at, and the urethral mass is surrounding. Oops. So staging for females is the same as male urethral carcinoma, the TNM staging that is. TCC of the prostate is staged separately. It's important to know that at diagnosis, 1/3 of patients have palpable nodes. 90% of these are malignant. So that's unlike penile cancer, where it's sort of a 50-50 of infectious versus malignant. Half of patients with proximal or advanced local disease have palpable nodes, and 20% have pelvic nodal mets at the time of diagnosis. Mets outside the pelvis is quite rare. This is the TNM staging. I'll just run through it quite quickly, just the T stage, so we'll talk about it a little bit later. T1, it's tumor invading the subepithelial connective tissue. T2, tumor invading the corpus spongiosum, prostate, periurethral muscle. T3, invading the corpus cavernosum beyond the prostatic capsule, the anterior vagina, bladder neck. T4, invading other organs. TCC of the prostate basically is about the same, so I won't bother to bore you with that. So management. So it's interesting that there's no significant differences in survival based on the histological subtype. So SEC, TCC, sort of the same survival. It's all very poor. Treatment is based on location and clinical stage mainly. Superficial disease has a better survival than invasive disease, and anterior lesions are associated with improved survival versus posterior lesions in both males and females. This is just a general overview of the management. We'll go through each in a little bit more detail, just so that you don't get lost. So surgery is the mainstay, so excision is the mainstay. Anterior control is better than posterior control. Usually, if you have a posterior lesion, they present with distant meds, local invasion, present a little bit more advanced. If it's in the penile urethra, your options are partial penectomy or radiation, only if they refuse surgery. Bulbomembranous tumors, you would perform a radical excision. And if they have an advanced disease or metastasis, you want to do multimodal therapy. In females, almost the same, distal, 1/3 of urethra, the anterior urethra there. Circumferential excision can suffice. Laser coagulation also been described. Proximal 2/3 of the urethra, if there's a lesion there, you want to do an anterior exenteration and plus or minus radiation or chemo. Generally, you want to be more aggressive. Looking at the outcomes, this is a study done by Dalbagny in 1999, male urethral cancer. He looked at, now all of these studies are quite small, so you got to understand the prevalence is quite rare. And all of these patients have poor survival outcomes, so follow-up is usually an issue too. He looked at 46 men with primary urethral cancer with a median follow-up of 125 months. The overall survival rate at 5 years, all comers, was 42%. If they had superficial disease, it was 83%. If it was invasive, it was 36%. So there's a huge difference there. And if they presented with anterior tumors, it was 69%. And if they presented with posterior tumors, it was 26%. So it was clear at that point that new treatment strategies were needed. So people started looking at different things that they can do, basically throwing the book at these carcinomas. So for high-stage disease, multimodal therapy was looked at. Giel and his group in 1998 looked at 21 patients with primary urethral cancer. The mean follow-up was 42 months. Overall survival was 62%. Again, their study is quite small, but there are some lessons to be learned. So for more superficial disease, they looked T8 to 2 and 0M0 disease, so just up to T2 disease basically. 89% were disease-free at 42 months. If they had more invasive disease, T3, T4, 42% were disease-free. Out of those patients, those more advanced disease patients, 10 had multimodal therapy, and they all had a different combination of chemotherapy and radiation and the amount of radiation. And so it was just a sort of a grab bag, but everyone had chemo, radiation, and surgery, and 50% were disease-free. 2 patients had surgery alone, and these did not, they survived, but they had disease recurrence. So advanced disease, they concluded, had a better outcome with multimodal therapy. Looking at the management in males, if it's in the penile urethra, if it's superficial, papillary, low-grade, or squamous cell, CIS, distal urethrectomy and penile urethostomy is the mainstay. TUR or local excision has been used, but not for squamous cell CIS. If there's infiltration of the spongiosum, and then if it's the distal half of the penile urethra, you can do a partial penectomy with a 2 centimeter negative margin. If it's in the proximal half of the penile urethra, total penectomy is recommended, and there's a 13% of local recurrence rate. There's no role for prophylactic lymph node dissection in urethral carcinoma. If there are palpable lymph nodes, you can conduct an alloinguinal lymphadenectomy if there are no pelvic or no distant metastasis. This is just a great picture at 7 o'clock in the morning of a distal urethrectomy with partial glandsectomy, and this patient was left with a residual penile uretherostomy. If there is tumor in the bulbomembranous urethra, we talked about it before, radical excision gives the best long-term control and lowest recurrence. There's poor survival for all forms of treatment. Generally, you conduct a radical cystectomy and pelvic lymph node dissection with total penectomy, plus or minus a resection of the pubic rami and the adjacent urogenital diaphragm if you want increased resection margin or control. So this is the portion of the pubic rami that is resected here. This is a complete en bloc specimen, cystoprostatectomy, urethrectomy, penectomy. They also taken the inferior pubis as well. We'll talk about radiation and chemotherapy in the management. There are few reports for early stage lesions who refuse surgery, but there are unknown long-term results. There's skin ulceration, necrosis, stricture, chronic edema that can result. It does not prevent recurrence, but it does preserve the penis. So it's really for patients who really don't want any excision of their penis or any kind of surgery. So, that's sort of their only option at that point. Chemotherapy has been looked at in some small studies. They've looked at MVAC for TCC and BMP against squamous cell. And multimodal therapy has just been generally advocated for advanced disease or metastatic disease. The most significant prognostic factors for local control and survival are the anatomic location and extent of primary tumor. This goes for females as well. As we talked about before, anterior lesions do better than posterior lesions. Superficial disease is better than invasive disease, and that's by a large margin. If the tumor is in the distal 1/3, the cure rate is actually quite good, 70 to 90% with local excision alone. If it's small exophytic with superficial tumors, you do a circumferential excision of the distal urethral portion of the anterior vaginal wall. T2, T3 disease usually undergoes radical cystectomy up to the level of the bladder with a diversion. Partial urethrectomy plus or minus radiation is also used. Recurrence rates is sort of 0 to 50%. Have a lot of complications. If it's distally, not too bad. It's mediatal stenosis, and spatulate the urethra at the time of the OR. They can end up with bad incontinence, and they recommended sort of approximate to the anterior vaginal wall and the labia in order to try to alleviate some of that, or a sling at the time.
Laura, just back on for the distal third of the female urethra, what about brachytherapy or immunotherapy? You got some options?
Well, there aren't any good studies showing that gives any good long-term results. And so if you can get 70 to 90% cure, sorry, should I repeat the question? Dr. Marston asked a question about distal 1/3 urethral tumors, whether radiation therapy such as brachytherapy has been looked at. So, with a 70 to 90% cure rate with local excision, people really don't want to take the chance. And so there haven't been any very good studies looking at external beam radiation for, distal 1/3 urethral lesions. We'll get back to the radiation and external beam for more proximal disease, though.
Just anecdotally, I had 2 cases like that had needles, and they died of the cost of about 6 years later from recurrence. It's very minimal morbidity from
Interesting. Looking at radiation in females, brachytherapy, external beam therapy, combined external beam and brachytherapy have been used. It can be shown for distal low-stage cancer. There was a small study by Gordon with an 84-patient series, 5-year survival, looking at 74% if part of the urethra is involved, 55% if the whole urethra is involved. A lot of people, quote this study for the radiation, but most of the other papers sort of talk about distal urethrectomy for distal tumors, because of the complications that were associated. So 20 to 40% of patients had strictures, necrosis, fistula, incontinence, vulvar abscess, cellulitis, cystitis. So it really, whether it was worth it or not, really needs to be looked at. Neoadjuvant irradiation has some survival advantage. Groin dissection, if there is recommended if, again, there are palpable nodes without distant mets, or regional adenopathy during surveillance. If it's in the proximal 2/3 of the urethra, it's more likely to be high stage, involve the vagina, bladder. With anterior accentuation alone, local recurrence is quite high at 67%, and 5-year survival is quite low at 10 to 17%. Combination therapy is recommended. Mean 5-year survival with radiation and surgery was 54% in a small study by Terry in 1997. Advanced female urethral cancer, meaning that it's tumor in a proximal location, it encompasses the entire urethra, it involves the external genitalia, vagina, bladder. Cystourethrectomy, pelvic lymph node dissection, and a wide or complete vaginal excision is definitely recommended with the first stage. And then you do a partial vulvectomy or labial excision, or inferior pubic remectomy if the lesion is anterior to the pubis, or resect the pubic symphysis. For advanced cancer, chemoradiation and surgery is recommended. For SCC, they recommended 5-FU and mitomycin C. That has been used. TCC is they've treated it with MVAC or GC. Gemcitabine cisplatin. Chemo acts as a radiosensitizer, and then they hit it with radiation. Anterior accentuation and high dose intrabrachytherapy and external beam radiation therapy may improve survival, and that was done by Dalbagny in 2001, and again a small study. So let's go through the urethral recurrence after cystectomy. About 40% of urethral recurrence is diagnosed within 1 year after cystectomy. That was a paper by Clark, which I'll review in a few seconds, by him in 2004. The median time to diagnosis was 18 months, and late recurrence has been reported. About 60% will have symptoms. So if they have a cutaneous diversion, they'll present sometimes with urethral bleeding. Hematuria, if they have an orthotopic diversion, present with urethral discharge or mass. It's definitely, these patients should move on to cystoscopy and biopsy of any lesions, and CT MRI is useful. It's thought to be due to the unrecognized urethral involvement at the time of cystectomy, tumor spillage or implantation, growth from a positive margin, or de novo TCC from field change, and this is thought to be the most likely reason for it. In males after cutaneous diversion, there's a 2.1 to 11% recurrence rate. Prostatic stromal invasion increases the risk of urethral recurrence. Post-cystectomy monitoring is usually urethral wash cytology every year. I don't know what our guys do here, if they do for post-cystectomy monitoring, urethral wash cytology plus urethrooscopy every year, post-cystectomy. What is your follow-up?
In general, it's just a physical examination. It's all risk stratified.
Mm-hmm. So.
The question is, who do you do your urethrectomy in?
So Dr. Gleave mentioned that they basically do a history and a thorough physical examination for their post-cystectomy monitoring here, and all of the patients are then risk stratified to see who gets what kind of more invasive follow-up. Treatment is usually total urethrectomy, including urethral meatus. So looking at predictors for urethral recurrence, so Stein and his group in 2005 looked at a large cohort of men, 768 men, post-radical cystectomy for bladder cancer, with a 13-year median follow-up. So pretty decent study. They found 45 anterior urethral recurrences at a median of 2 years. The probability of urethral recurrence was 7% at 5 years, 10% at 10 years. 129 patients with TCC involving the prostate were found, and there was a risk of 11%, and there was a 11% urethral recurrence in this group. If the patients had superficial prostate involvement, there was a 5-year recurrence risk of 12%. If it was stroma invasive, it was 18%, and if there was no prostatic involvement, there was 6%. They also looked at a number of other factors, different histologies and all of that stuff, and different lengths along the urethra and all sorts of things. And they found that the prostatic involvement, especially stromal involvement, was the most significant predictive of urethral recurrence. So how should the urethra be sampled to identify prostatic involvement? So we know that if there's prostatic involvement, they have a higher risk of urethral recurrence. So what's the best way to sample the urethra? So Lebrat and his group in 1998 looked at 118 patients with a minimum 10-year follow-up. It was a prospective study. This is a group in France. All underwent endoscopic lateromontanal biopsy. That just means that they biopsied TOR resection, the 5 and 7 o'clock positions lateral to the verumontanum, 2 weeks prior to their cystectomy. And they also had an intraoperative frozen section of the urethra at the time of the cystectomy. 106 patients were negative on both frozen as well as their biopsies, and 12 had TCC of both of them. And these patients went on to have en bloc urethrectomy at the time of cystectomy. 9 had negative frozens but positive biopsies, so intraoperatively negative frozen sections, but positive biopsy. And the urethra was preserved for these 9, and all of these were closely followed. And none of the 9 over the next 10 years developed urethral recurrence. So they concluded that the intraoperative frozen section of the apical prostatic urethral margin was sufficient to identify if there was prostate involvement, and therefore see whether these patients would be at risk for urethral recurrence. After orthotopic diversion, we're still talking about males here, recurrence rate has been quoted as 0.5 to 4%, so it is quite low, especially lower than the allele conjugate rate or the non-continent diversion rate. There's a low incidence if the negative frozen section of the distal prostatic urethral margin at the time of cystectomy, if there's a negative frozen. And post-cystectomy monitoring it can be voided urine cytology. Obviously, I don't think we do that here either, Dr. Gleave.
Probably to avoid the urine cytology with the orthotopic bladder becomes uninterpretable.
So Dr. Gleave's statement was that voided urine cytology in someone with an orthotopic neobladder is a lot of times indeterminate or unreadable.
So the question is there evidence that voided urine cytology with an orthotopic neobladder is interpretable?
Mm-hmm.
What's the positive predictive value?
Yeah, and so he was asking about the positive predictive value of voided urine cytology. So it was basically stated in multiple, studies that I looked at that voided urine cytology was one of the ways that they followed up their patients. But again, all the studies that I looked at, they had, they were in a study, so they also went on at 1 year to have urethrooscopy and all of that. So I don't know what the interpretation is of the voided urine cytology and how useful it is. Treatment, generally for CIS, you can try urethral BCG perfusion. If it's papillary or invasive disease, total urethrectomy with excision of the cuff or pouch of adjacent to the anastomosis, and cutaneous diversion, often using a portion of the existing neobladder is what is performed. So this is Clark's paper from 2004, looking at the predictors of survival. Over 1,000 patients post-cystectomy for invasive bladder cancer were looked at. It was a retrospective review. 47 men were diagnosed with urethral TCC. The median time to diagnosis was 18.5 months after cystectomy, with 40% being diagnosed within the first year. 60% of these, about 60% of these, are symptomatic, and the 31% who were asymptomatic had abnormal cytology. It didn't break down into which ones had voided versus just washes, and cytology was done yearly. 41 patients underwent urethrectomy, 38 underwent total urethrectomy, 3 underwent perineal urethrostomy. The overall survival at 26 months after the diagnosis of urethral TCC was quite low, 23% at 26 months. 21% of these, however, were disease-free. And they concluded that the stage, superficial versus invasive, at the time of diagnosis was most important predictor of survival. In females, there are few reported cases, so there's no real consensus. After cutaneous diversion, total urethrectomy is recommended. After orthotopic diversion, urethrectomy and resection of the area of the urethral pouch anastomosis, and then conversion to a cutaneous diversion is your next step, if, of course, there's the absence of mets. In 1998, Stein and his group looked at the predictors for urethral cancer in females. 71 female cystectomy specimens for bladder cancer, these are consecutive specimens, were looked at. There was a 19% incidence rate of bladder neck involvement. And once bladder neck was involved, 60% of these had normal proximal urethras. So 40% of those, so if they had bladder neck involvement, they had urethral involvement. 7% of patients had urethral involvement, and all of these patients had bladder neck involvement. So they concluded that bladder neck tumors had the most significant risk factor for tumor involving the urethra. Okay, so they have tumor at the bladder neck. How should you evaluate the urethra then for choosing who undergoes an orthotopic diversion versus who should just go on to an allele conduit? So 47 had intraoperative frozen sections of the proximal urethra, 45 had no urethral involvement, and 2 had urethral tumor, and all correlated with the final specimen. And so they concluded that they can reliably evaluate the distal urethral margin with the intraoperative frozen sections, so at the time of surgery. Just to touch on the urethral carcinoma within diverticulum, this comprises 5% of all female urethral carcinoma. Adenocarcinoma is the most common. TCC is the second most common. Diverticula, from my previous talk, occurs in females between the ages of 30 to 50 years old. It's thought to arise from obstructed periurethral glands, therefore obviously would lead on to adenocarcinoma. It's thought to kind of obviously move on to adenocarcinoma. Most of the diverticula, any changes within the lining of the diverticula are benign. Thomas's group in 2008 looked at 90 patients who had diverticulectomy. 6% had adenocarcinoma, and most patients, 66%, had chronic inflammation. The diagnosis, again, is made by thorough history and physical examination. And these patients then move on to cystoscopy and biopsy, and an MRI is very useful in in imaging these patients. Treatment, if it's invasive disease, anterior exenteration and urethrectomy is recommended. There's a high rate of local recurrence with subsequent need for anterior exenteration if diverticulectomy alone, and multimodal therapy may be advantageous. This is Gila's group again that we looked at before. There are 21 patients with urethral carcinoma. In that group, 4 patients had tumor within a diverticulum, and these presented with T2, T3 disease. They found that multimodal therapy was beneficial. You can see that there was the T2 disease, which was distal, was treated with distal urethrectomy, and 17 months they had a recurrence. All of these is they threw everything that they could at them. And then, sort of had these outcomes. but multimodal therapy was thought to be the most beneficial. These are some pretty pictures. This is a 69-year-old female with frequency and dysuria for the last few months. She had a palpable mass on the anterior vaginal wall. She had an X-ray which showed these radiopaque calculi in her pelvis. She then went on to have a CT. This shows your urethral mass with a big star on it. The arrows are pointing to those hyperattenuating calculi in the posterior urethra there. This is a T2 weighted MR. You see that hypointense urethral tumor here, just on the anterior aspect here. Posteriorly, you see your calculi. The Foley is sitting here. This is a T1 weighted post-GAD FACT suppressed image. See the enhancement of the urethral tumor. The Foley catheter sitting here, and again the calculi. And this is the pathological specimen after she had undergone anterior exenteration and total urethrectomy. You can see the urethral diverticulum here, big cancer within it, and the stones there. So in conclusion, urethral cancer is rare, but it's quite aggressive. For all comers, the survival is pretty low. Predictors of survival found to be stage at diagnosis and location of the tumor. Multimodal therapy seems to increase survival in advanced disease, but the optimal multimodality treatments is controversial, not clearly known. Recurrence, post-cystectomy, and tumor within a diverticulum really needs aggressive treatment. Thank you.